يوم 17 و 18 نوفمبر المؤتمر الدولي الثالث للعلاج الطبيعي.
نخبة من أساتذة كليات الطب المختلفة بموضوعات مقترحة منهم وبأبحاث جديدة.
المؤتمر البحثي الطلابي ان شاء الله يكون فيه اضافه كثيره للابحاث العلميه.
ندعو كل زملائنا الطلاب لحضور المؤتمر الدولي الثالث لكليات العلاج الطبيعي.
بمشاركة النقابة العامة للعلاج الطبيعي، المجلس الوطني للشباب، أكاديمية إيمز.
كراعي رئيسي للمؤتمر هنقوم بتوفير محاضرين دوليين من عدة دول.
مجال الإبداع الشبابي اللي هيكون الراعي الرئيسي للمؤتمر البحثي الطلابي.
بالتعاون وبالمشاركة مع الكوادر العلمية اللي موجودة عندنا في الجامعة وفي الجامعات التانية.
ورش عمل متميزة جدا من نخبة من الدكاترة المتميزين من خارج مصر ومن داخل مصر.
نرحب بكم جميعا، تشرفونا ان شاء الله.
حضور المؤتمر الخاص بالكليه، المؤتمر الدولي، ان شاء الله تشرفونا وتنورونا بالابحاث الجديده،
وان شاء الله يلقى عدد كبير ان شاء الله يشاركنا فيه وببحوثهم ومحاضراتهم، وباذن الله موفقين كلنا لصالح العلاج الطبيعي ومستقبل العلاج الطبيعي.
I invite you all to our third International Physical Therapy Conference, which will include a lot of scholarship and opportunities for you. Come join us in our humble university, MTI.
صباح الخير. شير بيرسون دكتورة بروف دكتور ألفة دياب، Dean of Faculty of Physical Therapy, MSA University. بروف دكتور عدلي صبور، Dean of Faculty of Physical Therapy, BAD University. بروف دكتور خالد عياد، Dean of Faculty of Physical Therapy, درايا University. وبداية أول محاضرة مع بروف دكتور بينار، Assistant Professor, Istanbul University.
Thank you. So, welcome to everyone. I'm very excited. And I will talk about now Parkinson's disease evidence-based treatment planning. And Parkinson's disease characterized by death of dopaminergic neurons in the substantia nigra pars compacta. It's not working, I think, and is a slowly progressive neurodegenerative disease that caused by a combination of genetic and environmental factors, involves multiple neuroanatomical areas, and dopamine decrease, also direct pathway decrease, and less motor activity appears, and begins many years before the diagnosis and has a premature phase with symptoms such as constipation, sleep behavior disorders, beginning 20 years before diagnosis, and also continue throughout the disease as non-motor symptoms such as pain, demands, orthostatic hypotension, and increased ganglion output results in bradykinesia, hypokinesia, motor freezing, gait disturbance, hypertonus rigidity, also tremor, and the most commonly used scale to measure the disease level, we use the Honian Yard scale. It starts with just unilateral involvement only, and then until to wheelchair dependence. And which problems should we focus on while planning the physiotherapy program in people with Parkinson's disease? And the axial hypertonicity and rigidity, so they can't move their center of pressure or center of gravity to different directions, and they have postural instability causes as slower and decreased center of gravity displacements you see in there compared to healthy individuals. And they have a lot of biomechanical limitations leads to postural instability. One of them is muscle weakness develops secondary bradykinesia because of decrease in cortical outputs, and especially in trunk and lower extremity extensor muscles, strength decreased. And they have flexed standing posture and decreased range of motion in their joints, and they have narrow support surface, and all these biomechanical limitations leads to postural instability. Also, they have a lot of postural deformities because they have dystonia, rigidity, drug use, and you see in A, captocormia, and you see in B, antecholis, Pisa syndrome, also scoliosis, and all these postural deformities led to postural instability. They have impaired postural reactions, and they have partially difficulty resisting perturbations to backwards direction. Also, they have problems to external anterior directions, and forward compensatory stride lengths are and require multiple strides, and which is associated with higher risk of falls. Also, they have excessive coactivation in their muscles, you see, and they have problems to resist external perturbations because of it. And they have sensory integration problems, especially in maladaptive sensory conditions, such as eyes closed and standing in different ground surfaces. And they have limited aerobic capacity, increases fatigue in their daily activities. They have low levels physical activity, we should increase, and more than 70% of these patients adopt an inactive behavior on inability to take voluntary steps, gait asymmetry, and freezing, dynamic postural control. And you can see there, but while they're turning, they have slower steps and a lot of steps while turning. And they have dual task gait problems when performing an additional motor or cognitive task in their life. They get disturbances worsen. And so before we planned the exercise training, guidelines advise that set SMART goals. It should be specific, measurable, and attainable, and realistic, and relevant, and time-based. And guidelines suggest, advise, use cues. It's very important. Parkinson use cues while training gait. In one study, they investigated the queued up program, false prevention program for these patients, and they advise protocol, and it's feasible and beneficial for these patients, and a lot of a variety of exercises they performed with metronome instruction, such as seated weight shifting, standing march, seated march, sit to sit, and weight shifting with metronome instruction, and turning, opening doors in home or outside. They use metronome cueing, visual, not visual, auditory cueing. And there was a video, but I can't, I think, watch, you can't watch it. Okay. Other studies compared different cueing forms, which is auditory and visual cueing. And they advise that if we want to improve temporal parameters such as cadence and gait velocity, we should use auditory cueing. But if we want to, if we aim to improve, we should use visual, such as stride length improving, and auditory cues. They concluded that auditory cues are a better method than visual cues for gait rehabilitation in these patients, because our auditory system is more sensitive to processing temporal information than its reactive visual system. Then we should use auditory cues to improve temporal parameters, which is most problem is in these patients. And guidelines recommend strongly using gait with cueing to improve walking speed. And they advise provide physiotherapist supervised training, but support by fast exercise on other weekdays, and use exercise diary, and train cueing for a minimum of 3 weeks, 3 times a week for 30 minutes. And we can use tape on the floor, leather as a visual, metronome, preferred music as an auditory, and vibration rhythm of a vibrating wristband as a tactile cue. So how can we determine the frequency of cue? And we will give exercise to our patients. So how can we determine frequency? We can determine firstly baseline step frequency with a 6-minute walk test and 10-minute walk test. And then in non-freezers, we can use up to 10% above baseline frequency. If we aim to improve gait instability, mostly in patient's home, up to 15% below baseline frequency. In freezers, we should use up to 10% below baseline frequency with metronome. And they advise that use essential strategies like think about taking big steps, or make wide turns, or rock left to right before starting to walk, or rock your bend knees from left to right before rolling over, or taking a step backwards before starting to walk. Other, we should focus on the balance. Other parameter is the fall rates in addition to positive balance and walking results, and service is more effective in improving balance. And their research, they explained their exercises in detail. For example, they use the patient stance on normal overground, stance on unstable surfaces, or gait test. In other group, they compared progressive resistance exercises with balance training, and control group received stance on hip flexion, hip abduction, and resistance. Interestingly, resistance exercises improved balance parameters, but balance exercise group UPD score only improved. And all research advice, if we plan balance training program, it should be highly challenging. Then when planning exercises, it should be aimed to address one or more of the 6 balance control systems, progressing from the less difficult to the more difficult, such as strengthening, range of motion exercises, anticipatory and reactive balance exercises, change sensory input, and gait training should be included in this program. And other progressive resistance exercises are other exercise variety, I can say. Progressive resistance exercises is very important in these patients and should be applied to increase muscle strength and endurance. And in study, they progressive resistance exercises affect their research, and compared to modified fitness counts exercises, which control group received. These modified fitness counts exercises included standing stretch, seated stretch, or standing strengthening exercises, seated strengthening exercises, and balance exercises, which received progressive exercises, chest press, lateral pull down, reverse flies, double leg press, shoulder press, and they progressed the exercises. Firstly, they determined one maximum repetition and increased the resistance 5% as tolerance increases. They progressed the sets, and they added the program after 8 weeks to 2 sets, 12 reps, changed to strength and speed training program every 8 weeks for 24 weeks. And they concluded that the training group had better UPDRS scores than PRE's training slows the progression of the disease and should be a major component of exercise programs that include balance training. Sorry. And exercise with virtual reality is very trend in Parkinson's disease, and with V-Remote, the balance and fatigue differed significantly after the study, and but this benefit wasn't sustained in the long term. With kids, their gait speed improved and quality of life improved also. And based on a coherent review of seven studies, virtual reality exercises increases strength length in the long term, and provides similar short effects and long-term effects, balance, gait, and cognitive function. And okay, virtual reality exercises has carried effects, improvements in balance and walking. And body weight supported treadmill training is also effective in these patients. And stroke they recommend strongly to use this body weight supporting treadmill training to improve walking speed and stride length. And they advise when we use treadmill, take into account cognitive and physical ability. And if they have freezing gait, take care when accelerating and decelerating the treadmill, and train at minimum 4 weeks, 3 times a week for 30 minutes, and ask your patients to focus on large steps, give feedback such as using cues, and consider adding a cognitive dual task and placing a mirror in front of the treadmill. And you should beware of underdose prescription of exercise when you use treadmill, and gradually increase your intensity based on perceived exertion, heart rate, and walking speed. And exercise with Tai Chi also has positive effects on balance, walking, and mobility in these patients, and also beneficial in improving mental mood, behavior, and quality of life for these patients, and reduces the frequency of falls up to 6 months after training. And they advise for Tai Chi, train a minimum 24 weeks, twice a week for 60 minutes, and support your patients towards non-physiotherapy supervised with intermittent follow-up. And guidelines advise that, recommend strongly to use Tai Chi to improve movement functions, and dance-based exercise also effective in as it has been getting more attention by these patients in recent years, especially Argentine tango dance. And why is it effective? It encourages various cue strategies. Patients take a lot of steps, turn, walking in different directions, and it can improve movement, initiation, speed, and rotation. And Tango has auditory cues, also visual cues when they follow their partner through coordinating steps, and it reduces freezing during walk, and train a minimum of 10 weeks. They advise twice a week for 60 minutes. Also, Qigong exercises, yoga is effective in these patients, and guidelines advise that use Tai Chi and treadmill for walking speed. Strike.
It's very interesting talks, but it's really
It will
restricted
be.
for schedule.
Okay.
So it's only one slide. It's only one slide. It's
Okay.
only one slide.
You can use this case when you want to follow up your patients, and you should increase you should increase the physical activity level.
And thank you for everything. Your presentation was very wonderful, and we are very thankful for your presentation.
Okay.
Thank you, Dr. Binar.
Now, we are waiting for Professor Dr. Muhammad Quraim.
Stay on your seats, please. And now it's our great pleasure to introduce the next speaker, who is Dr. Muhammad Quraim. Dr. Muhammad Quraim is consultant and lecturer of general surgery. He is going to talk about sportsman hernia, the ugly side of sports. Thank you.
Good morning. It's my pleasure to be here. This is not my talk. This is not my talk. This is not mine.
Okay.
This is it.
Okay, now we can start. You have 15 minutes, Dr. Muhammad.
Okay. The issue of this topic begins from a very basic principle we have been taught at the start of the college. They told us, you have to know what are you searching for? Why are you prescribing this medication? Why are you rating this prescription, this regimen? You have to search for three aspects. What are the pathophysiology of the disease, and consequently, the medication you are trying to prescribe. Second, what are the benefits you are searching for? At one are the adverse effects you should avoid, or you should manage if it is inevitable. The same applies here. At the start, kinds of exercises, endurance, strength, balance, and flexibility, according what you are searching for, what you are trying to exercise, which muscle you are adopting. You are searching You are searching for good impacts, either in the short term or the long term. Increasing the blood flow to your body, increasing your alertness, your muscle flexibility and stability to avoid other adverse effects and long-term impact like muscle hypertrophy, increased stores of glycogen and creatinine, increasing vascularity. It's life. No pain and no gain. In other words, we can reverse it to something. No gain without pain. They have been told, according to the Greek mythology, everything is toxic, but it's all about the percentage. It's all about nothing is pure benefit and nothing is pure harm. Like Mark Twain said, everything costs something everyone has to pay. This applies to sport. This is the ugly side I mean. You can have overuse injuries and collateral damage if this unplanned. Something very enthusiastic, going to exercise and practicing very much to get results at short term, you will have injuries. Is this inevitable? And this damage comes from the basic principles. Acute response of skeletal muscles exercise damage. Microtrauma occurs to the microfibrils, the minute structures of the muscles, inducing inflammation, which induce the pain. We have loss of muscle function, neural to some extent, with delayed onset muscle soreness. This is experienced by everyone starting exercises early. After the first exercise, he will have soreness. He is unable to get off chair, like they say. What is this? Point. This applies to the pelvis, a bone structure that have to stabilize the body to gain the weight, transfer it from the trunk to the lower limb, depending on certain joints like sacroiliac, like the iliopubic, and the interpubic bone, the symphysis pubis. It's stabilized by muscles, but muscles is not the only player. Muscles will be hypertrophied, will get intolerated to this exercise. But what about the ligaments? You have the pelvis, much of the ligaments stabilizing the iliac bone, the ischial bone, and the pubis bone to the lower limb, the femur. You have sacroiliac, joint anterior sacroiliac. You have the sacrotuberous and sacrospinous. You have the iliofemoral, much ligaments to stabilize the pelvis. I'm trying to say the pelvis, this bone structure is very important to gain the weight of the body, transfer it to the lower limb, has not to be overstretched. Overstretched exercises, unexplained or unplanned exercise, unplanned forces existed on these ligaments will cause its inevitable tear. Function overload, sudden and rapid eroding, rotational and twisting. This movement, you have to stabilize your lower half while rotating the upper half, will cause strains and stress over the ligaments, causing its tear. Enough of this basic science. We are talking about hernia. And what's hernia? From our medical perspectives, hernia is an abnormal swelling at the lower part of the body or at its sides. The sides of the hernia are known for us. But what about sports hernia? It's a pain syndrome, not actually a hernia. Pain syndrome at the lower abdomen and groin, originally seen in sportsmen, and this is from which it came its name. Many other names are given to this syndrome. Gilmore's groin is the most important. Inguinal pain syndrome, sportsman groin names. It's a disease not fully understood. And everything that's not fully understood have not a consensus 100% about its management. This is its problem. It's not fully understood, but to large extent, experts said it's mainly treated by physical therapy, not surgery. Against all other hernia, it's treatment by physical therapy. This is the main line of treatment. Its prevalence in sports, especially those requiring your twisting of the body, like rugby, like football, like Australian football, and cricket, skiing, the sports, kind of sports requiring discrepancy between the movement of the upper part and lower part of the body. Risk factors can be predicted. All what puts stress on the pelvis is a risk factor. Forceful and repetitive movement of the hip, weakness in the abdominal wall muscles, vigorous exercises, and imbalanced stretch between the hip and the lower part of the body. It's disturbance of stability. So this is to sum up. Starting, it describes it as inguinal disruption caused by tear in the inguinal ligament, tear in the external oblique, tear in the rupture in the conjoint tendon, and widening of the external ring, the distance between the inguinal ligament and ruptured conjoint tendon, to be followed by Milicia and Lovell. It is an initial stage for development of direct inguinal hernia. Direct inguinal hernia is actually a weakness in the posterior wall of the inguinal canal. If this wall becomes weak, it will produce direct hernia. This is an intermediate stage before the developing of. For its diagnosis, we have a criteria, and this criteria compels us to have 3 out of 5 in order to diagnose this patient with such a syndrome. They have point sensitivity at the conjoint tendon, sensitivity to palpation at the deep inguinal ring, and pain at the outer part of the ring, pain in the adductor longus, diffuse inguinal pain that may radiate to the perineum. Like we are seeing, it's all pain, 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 with no physical findings. It's all about inguinal disruption, injury. This is to sum up. The clinical examination actually is intended to get this criteria of pain at the lower part. You see the external ring, the adductor tubercle, the conjoint tendon, and exclude other differential diagnoses, rupture of the muscles, rupture of the adductor longus, and the clinical tip for us. Every pain above the inguinal ligament can be an sportsman's hernia. Unlike the pain below the inguinal ligament, it's mostly according to other cause. Pain is the cardinal sign in this disease. Investigations will not help much. It will be ordered for the other differential diagnoses. It's mainly a clinical diagnosis. We can order investigations for the etiology, not for the diagnosis, like MRI, dynamic ultrasounds. This will help us to exclude other differential diagnoses. Prevention by adequate planning of your training. Don't be very enthusiastic. Don't rush into your exercise. Your body has limits, and you have to respect these limits. You have minimizing the risk factor. You have to follow up individuals that are at risk. And like management, you said, conservative management with physical training is the main line, and last comes surgery. For us, if a patient comes complaining of the lower part of his abdomen with no apparent swelling, we'll say you have risk factors and you should go for a physical physiologist specialized in the groin pain. You have to be followed for at least 3 months before trying to do anything or surgical for this patient. No treatment from our side unless there is failure of conservative management. And our treatment will go to reinforcement of this part, either laparoscopic or open. This is our surgery, and it's not our scope here. Thank you.
Thank you, Dr. Karim, for this great lecture, and thanks for being limited with your time. Exactly.
We introduce Dr. Mohammed Abdulrahman. Breast cancer. related lymphedema.
Good morning. Good morning, everybody. I am Mohammed Abdurrahman, Professor of Clinical Oncology, Qasr Al Aini School of Medicine. First, I'd like to thank Professor Olfat, Professor Naguib for the kind invitation. Thank you, Chairman. Excuse me, I'll take you for a journey in 15 minutes with our breast cancer patients in an interdepartmental lecture that needs collaboration of you as physical therapists with us as oncologists, in addition to other specialties like cancer surgery, plastic surgery, nutrition, and other specialties. This is the scope of our lecture. First, breast cancer is the most common cancer in females. About 1/3 of cases of all newly diagnosed cancer in females, and about 15% of all cancer. Surgery is the tool of management of non-metastatic cases. Patient journey usually starts while investigating a painless, painful breast lump, sometimes accidentally discovered, or even during routine screening for non-symptomatic patients. During this screening, mammosonography is the investigation of a choice. After doing the mammosonography, this is a mammography picture, this is the sonography. If you have a suspicious lesion through the BI-RAD classification of mammography, you should go for biopsy. And the biopsy is the best biopsy for diagnosing of breast cancer is the true-cut needle biopsy, usually sonar guided. After the biological confirmation of cancer, and if proven non-metastatic, the best method to treat patients with non-metastatic breast cancer should be inside the disciplinary team. The multidisciplinary team discuss the case and tailor the best treatment for this patient based on different biological, anatomical, and other factors. After the discussion in the MDT, the multidisciplinary team management, the patient is treated with surgery as the definitive treatment that may be preceded by systemic treatment, which is called neoadjuvant, or followed by the systemic treatment, which is called adjuvant treatment. The definitive surgery now is mainly two kinds, either modified radical mastectomy or breast conservative surgery. Modified radical mastectomy entails removal of the whole breast and keeping the pectoralis major, not like in the radical mastectomy. While in breast conservation, of the tumor with safety margin, and in both surgeries, we have axillary surgery, starting from sentinel node dissection from 2 to 5 lymph nodes up to extensive axillary surgery, which is not being done nowadays a lot. And in both cases, most of patients will have post-operative radiotherapy, which is mandatory in breast conservative and optional in mastectomy and given in early stage. This is the conservative surgery nowadays, and this is the mastectomy which has been described thousands of years ago. As I mentioned, radiation therapy is given after both surgeries to the breast or the chest wall, including peripheral lymphatic, supra-infraclav, internal mammary, and axillary lymph nodes. So the axilla have been treated twice. First by axillary surgery, and second by radiation therapy. And both will cause fibrosis. Fibrosis will cause obstruction of the lymphatic drainage, resulting in the problem which is called breast cancer-related lymphedema. So this is lymphedema is an accumulation of protein-rich fluid in the interstitium. If complicating management of breast cancer, this is called breast cancer-related lymphedema. The incidence of breast cancer-related lymphedema ranges from 10 to 50%. This depends on the extent of the axillary surgery, axillary irradiation, and also on the patient body mass index. If you have a body mass index of more than 30, which is very common in Egypt, you will have tripling of the problem, tripling of the incidence of this problem. To evaluate breast cancer-related lymphedema, many methods have been described. The most popular is to measure multiple measures at the olecranon, 10, 15, 20 centimeter above, 10, 15, and 20 centimeter below, in addition to the measurements at the carbo-metacarpal joint and the wrist. And these values will enter a computer calculator that evaluates the volume of the limb. If you compare both limb volumes, you will have difference between the affected limb and the sound limb, and this is the then the patient is classified according to many classifications. So important, or the most simple, is the American Physical Therapy Association, which classify patients into mild and severe according to the difference if it is less than 3 centimeter, 3 to 5, or more than 5 centimeter difference in this limb circumference. To manage lymphedema, we have prevention first, and then we'll go to talk about the management. Prevention through less axillary management. As I mentioned, the pathogenesis of lymphedema is axillary surgery, axillary radiation. If you have less extent of axillary surgery and radiotherapy without affecting negatively the tumor control and survival, this will affect lymphedema and reduce the incidence and the extent of lymphedema, of course. Other measures like avoidance of infections and trauma. For therapy, we have to discuss the role of physiotherapy, which is the most important role in daily practice, role of plastic surgeon, and our role as oncologists. Starting with the prevention, this is a lot of studies that compare less axillary surgery or replacing surgery with radiation therapy has shown that the incidence of lymphedema and the need to treat lymphedema is less. One of the most important studies is the European Organization of Research and Treatment of Cancer study, which randomized patients with positive sentinel node, which is standardly treated with axillary dissection, to be treated with axillary radiation instead of surgery versus the standard arm of axillary dissection, and that there is no statistically significant difference between the risk of axillary recurrence in both groups. So we have the same control with radiation therapy or with surgery, with, of course, less incidence of lymphedema in the first graph and less incidence of lymphedema in the second one. Coming to the other methods to prevent lymphedema, we have to treat infection early. We have to avoid infection first. We have to avoid trauma, treat infection as early as possible, as this limb has reduced local immunity. Coming to the therapy, starting with the of the multidisciplinary. As the cancer patient is managed in a multidisciplinary team, we have to manage lymphedema also in a multidisciplinary team, starting with me as oncologist who selects the patient to the team. The first one assists the patient, the team is the physical therapist, which do his assessment and start the treatment. If survival is good and the treatment of physical therapy failed, which occurs in rare cases, we have to go for the plastic microvascular surgeon. Then after finishing the surgery, we resume oncological treatment. This is the dynamics of multidisciplinary team management for the management of lymphedema, in addition to other specialties needed like nuclear medicine and diagnostic radiology. The role of physical therapy, the standard management is combined decongestive therapy, CDT. I'll not talk about CDT in presence of all of you. CDT formed of 4 major steps: skin compression through bandaging or pneumatic, and exercise. I'll not go into detail as I mentioned. For the role of surgeon, first when to do surgery and what surgery to be done. What surgery to be done? Decades ago, excision surgery is now obsolete. It is microvascular plastic surgery. So the indication of microvascular plastic surgery is failure of the physical therapy management, important indication. Other indications like disfigurement and recurrent cellulitis, or disfigurement and limitation, extensive limitation of functions. This is the indication for surgery. What surgery? We have 2 major surgeries. First is the lymph node transfer, most probably from the groin, from the inguinal lymph nodes. Second, lymphovenous shunting, a micro shunt between the vessel and the venous vessel, so we can avoid the lymphatic obstruction through the venous pathway. Another surgery is the combined rectus abdominis flap with the vascular lymph node transfer. This is only done if you have mastectomy, not breast conservation, and you are going to reconstruct the patient like this. This is the reconstruction from rectus abdominis in addition to the groin lymph node, vascular lymph node transfer. This is our Qasr Al Aini Center of Clinical Oncology, and this is our success story. We applied the dynamics of MDT starting from Jan 2020. Starting with breast oncologist, it was me, and the microvascular team led by Professor Ashraf Abu Futuh, professor of vascular surgery at Qasr Al Aini, and you have our physical therapy team, which is led by Dr. Heba Al Awadi, a consultant of physical therapy. She has more than 15 years experience in the physical therapy of cancer patients, in addition to her team, which is 4 physical therapists. Started at Jan, as I mentioned, we was meeting on weekly basis, but unfortunately started at Jan, and by 11, the WHO announced the pandemic of COVID-19. So we shifted to the online meeting. Fortunately, online meeting allowed the joining between the 2 MDT, the MDT for breast cancer management and the MDT for the lymphedema. We have seen more than one in about more than 2.5 years, and we have treated 20 patients with surgery. The most important surgery was, the most common surgery was the lymphovenous shunt in 10 patients and the vascularized lymph node transfer in 7 patients. This is our physiotherapy unit. It's formed only of 3 rooms. They treat about 50 patients per month. And if the patient will be treated only for 4 weeks with 3 sessions per week, so we'll have 12 sessions per patient, 12 times 50. So we have to give 600 sessions monthly for the management of breast cancer-related lymphedema. The CTD consumes about, I think, 1 hour and 15 minutes. So we have to spend more than 750 hours in the management of this problem at our department. As I mentioned, we have 4 physical therapists in addition to the team leader. So we have 5 physical therapists working for about 1,000 hours per month. So you have to spend more than 70% of your time in the management of breast cancer-related lymphedema, only one complication of only one cancer, which is breast cancer, in a highly specialized, highly overloaded department like our department. This is useless. We cannot do this. So we should have to search for an alternative. And this alternative should be safe, should be time-saving, should be relatively cheap, and not difficult to train for the physical therapy, and should be comparable in efficacy, not sure to be better, but at least to be comparable to the standard CDT. And we searched about the low-level laser therapy. Low-level therapy, and now the question is, can low-level laser therapy used as a practical alternative to CDT or not? And to answer this question, we have conducted our trial over 40 patients, less than 40 years, caring about their lymphedema and their cosmesis, aggressive surgery, mastectomy. And we published this trial 2 years ago or 3 years ago. This is our inclusion criteria, as I mentioned. All patients have been evaluated pre and post-treatment with circumferential limb measurements and quality of life questionnaire, which is the ULL questionnaire, formed of 3 parts: physical, social, and psychological questionnaire. This is the questionnaire, and this is the treatment arm, this is the laser arm, and this is the standard CDT arm. This is our patients. Both groups with treated with laser and CDT were comparable regarding age, weight, axillary surgery, extent of axillary surgery, size of the limb, either the sound limb or the treated limb, and the baseline questionnaire level, the quality of life at baseline, were comparable. Regarding the limb volume has been significantly reduced in both arms, with non-significant improvement, better in the standard CDT. So we have no statistically significant difference in the improvement in the limb volume between both techniques. Borderline statistical significant improvement favoring the CDT regarding the physical score, but no significant difference regarding the psychological score. And the most important finding, psychological or social score, the most important finding of our study is the treatment time. The treatment time was more than 70 minutes for the CDT arm and less than 20 minutes for the laser arm. In addition, laser requires literally, I will not say no treatment, no training for the physical therapist. So our conclusion that CDT only borderline significant improvement regarding the HLL quality of life physical score over the laser therapy. But laser therapy is comparable to CDT regarding the reduction in the limb volume, the social and psychological score improvement. And so we considered laser as a practical alternative suiting our workload at our department. In conclusion, breast cancer-related lymphedema is an important problem facing breast cancer patients after treatment. The management needs collaboration between you, us, and the microvascular plastic surgeon, with the most loaded person in this management is you, the physical therapist. We tried to use a practical alternative, which is low-level laser therapy. It was proven to be not inferior to CDT regarding the psychological score, the social score, and the volume, but maybe less than CDT regarding the improvement in the physical score for the quality of life. Physical therapy, as I mentioned, is the most burdened person in the management of breast cancer-related lymphedema, and this is our way to overcome this problem. We are planning in the future to study the combination of low-level laser therapy with part of the CDT, which may be the pneumatic operation. And thank you.
Thank you for nice presentation.
شكرا.
Discussion are open now. If there is any questions for the speaker, please. People. Hi. If there is any questions for the third speaker, for the first speaker, can I invite the speakers to the board, please? Can you come with us, Manner? And the speaker are invited to be here. If there is any questions for the speaker?
Dr. Mohammed Kraim. Prof. Dr. Binar, تفضلي. Prof. Dr. Mohammed Kraim. Prof. Dr. Mohammed. شكرا. lagi. شكرا دكتورة بنار، شكرا دكتور محمد، شكرا دكتور محمد. دكتور نجيب. نشكر بروف دكتور ألفت. بروف دكتور عادل صبور. بروف دكتور خالد عيان. شكرا يا دكتور، ميرسي لحضرتك. ميرسي يا دكتور، ميرسي يا دكتور. Starting next session مع بروف دكتور هالة قاسم، Dean of Physical Therapy, Faculty of Delta. بروف دكتور عبير الويشي. بروف دكتور عزة فكري. مع الفيرست سبيك في النكست سيشن مع دكتور محمد عبد المجيد Lectures of Orthopedic Physical Therapy Cairo University.
Assalamu alaikum. Dear respected professors and colleagues, good morning. Bismillahirrahmanirrahim. My topic today is based on a research study we conducted like a couple years ago, and it was on the femoroacetabular impingement. We conducted an impairment-based physical therapy programs for runners with femoroacetabular impingement. That was with my team. بس مش بينقل بس. قرب يعني ولا؟ The paper was recently accepted for publication in the Journal of Health, Sports and Rehabilitation. Running as a sport is a popular sport in the States, and around 20 million people running in a different form. That's because it has a wide popularity and wide physiological and musculoskeletal effects. And this comes on the expense of some overuse injuries, especially musculoskeletal injuries. For the femoroacetabular impingement, the exact etiology is still yet not known, but there is some speculation about how the mechanical degeneration and the abutment of the articular surface after the abnormal morphological changes happen produces this condition. So in the femoroacetabular impingement, there is abnormal morphology in the articular surface of the hip, either in the femoral part, or the acetabular part, or both. When it happens in the risk factors are many, will include like patients with hip dysplasia, patients who were born with acetabular retroversion or develop that with time, or acetabular profunda or protusu. This abnormal contact surface will cause impingement during movement. For the femoroacetabular impingement, we have three types. One called is cam impingement, where the abnormal morphology happens in the femoral part of the joint, and the pincer impingement, the abnormal morphology is the abnormal shape of the acetabulum, or the mixed type, where normal morphology is in both sides of the joint. Patients with femoroacetabular impingements would present with pain, limited range of motion, probably with walking, running, ascending and descending stairs, probably with clicking, popping sounds during movement, especially in the flexion, adduction, internal rotation, which considered to be the impingement position at the hip. Patients will have pain with modified circumduction test, which is a provocative test, where you take the joint, the joint into flexion, adduction, and external rotation, apply a stress force, and then move the joint into flexion, adduction, internal rotation, maintaining this compressive force. Patients should produce pain in this last position, the flexion, adduction, internal rotation. So the MRI can help in the diagnosis. The treatment are many. In our study, we used three different treatment methods: manual therapy, dynamic neuromodulation, and functional training. The manual therapy has some moderate evidence in literature to increase range of motion, improve mechanoreceptors, and improve motor control. The functional rehabilitation, which is advanced training, performed at the end of rehabilitation program, which is kind of a sport-specific training. Since this is an impairment-based approach, we have to return these patients to running. So we have to apply this functional exercises program at the end of the exercise program. And I think I skipped, the dynamic neuromuscular stabilization. This is where the orthopedic physical therapist sneaks into the world of the pediatric physical therapist based on the developmental positions of the developmental kinesio. And it was first described by the Czech physiotherapist Pavel Kovar, and it involves putting the adult patients in a position similar to the developmental positions of the child, and apply the exercises in these positions. It was found sensoriomotor, proprioceptive, and motor control effect if you put the adults in these positions and apply your exercises in it. In this study, we used this 7-month oblique set positions. I will show it in the exercises program. So our purpose was to provide or to describe a multimodal exercise impairment-based approach for patients, amateur runners with femoroacetabular impingement. We had only 2 patients in this case reports. The patients received 32 and 24 physical therapy visits. Their score, pain score was 7 and 6, and the discharge score was 2 and 2 at the discharge. For the function, we used the patient-specific, which is a specific scale, a unique scale other than the patient's reported outcome. In this scale, the patients list at least 3 functional deficits, 3 functional movement that he cannot do, then rate each of these functional or exercise or positions. What's unique about this is it's in the patient's perceived outcome. So you don't have any involvement in this. You ask the patients what are the 3 most common movement or function that you cannot do, and how much is you cannot do scale out of 10. Since this was a case report, we don't have a control group to compare our results against. So we have to use some psychometric properties of the outcome measures, one of which is called minimal clinical important difference, which is the minimal treatment effect, the minimal meaning effect that you want to detect in the study. The VAS, the visual analog scale value for that is 1.37, meaning that the patient has to achieve a score more than this to be meaningful outcome for the patients. Same for the patient-specific functional scale, it's 2 to 3 points. So the patient has to change at least 3 points in order for the change to be meaningful. And for the global rating of a change, it's only one item question asking the patients to rate the progress from from pre to post treatment. And again, this is a case report, so we have to use these kind of statistical analysis since we don't have a statistical analysis, a complete statistical analysis. All right, so my life would be much easier if we move faster. Okay, so for the patient-specific functional scale, our patients listed these functional abnormality: running for more than 10 minutes, deep squats, sitting or on low stool, long distance running, sitting on my desk for more than 20 minutes, and pivoting on my right leg. The scores at baseline was low, at the charge almost 9.3, which is high enough, more than the MCID value for the questionnaire. Since this was an impairment page, we have to use a thorough physical examination in order to tailor the treatment to the findings. So in these patients, we didn't find, when screening the lumbar spine SI, something outstanding. For the hip range of motion, it was found that the flexion, adduction, internal rotation range of motion was mostly predominantly limited. For the functional problem, for the functional part, the provocative testing, the flexion, adduction, internal rotation, the three listed problem that they list in the scale, we also conducted, and we found it to be limited or painful with limping, difficulty to perform. Our treatment approach started with manual therapy, as I said. So we started with manual stretching, either in a Thomas position like this, or we asked the patients to perform the stretching at home with a self-assisted band stretch. Then we opted to use the mobilization with belt in a functional position. Again, there was an impairment in the flexion, adduction, internal rotation. Our treatment increased this range of motion. The only thing I would stress here, this is management position. We shouldn't try unless we know how to do it, because this will increase the patient. That's where Maitland stresses on the continuous assessment during performing of the maneuver, because if you just did the maneuver, this will likely to provoke the symptoms. But if you take the joint and move the joint with movement, and then ask the patients with which is limited part, you stop there, you back off a little bit, and then you perform the distraction and move again to a new range. Other than this will be useless, probably will be more destructive to the patient, all right? And then the DNS technique, we used this position called the low oblique set position, and we modified the positions by adding resistance and or stabilization to the joint. And also we used this technique called hanging technique, where we activate the whole posterior chain with the glute, using the core muscle to control the movement. For the functional approach, we used 7 exercises approach to stress the joint in a functional position: the side stepping, the side sliding, the leg press against a reformer, and this reformer had a resistance we can adjust in order for our patients to challenge the exercise basically. Also, we use this step up, a semi-unstable surface, and an opposite form, an opposite ball, sliding with a TheraBand around the limb, an unstable surface, again with the resistance applied. And also this challenging exercise is very good for the patients and it's very hard to attain, which is performed at the end of the exercises program. All these exercises were performed for 3 sets of 10, and if there is a hold, whether a hold for seconds at the end of the exercise. Our improvement in pain was 86 and 88. Again, this is relative to the MCID values I explained before. The function was 75 and 64. So we can say that the improvement that we had in this case series is reported with values more than the MCID values. So we can conclude that the improvement can be attained with these kind of exercises. The MCID values may be necessary in case series where there is lack of control group, as explained before. Some other studies found similar results. with their comprehensive impairment, which included similar exercises other than the DNS exercise. The DNS 7-month oblique set positions, we think it improved the congruency of the limb and centration. So now the 3 colleagues that did this paper with me were actually certified DNS practitioners. And there was a continuous discussion if we modified the original position, the 7-oblique-month position, we made sure that the modification will improve or augment the effect, not to defeat the purpose. So we made sure that the exercises are beneficial for the patient. The DNS can be viewed as the building block, where more complex tasks can be performed. We cannot infer, since this is a case report, we cannot infer a cause and effect. I'm sorry. We cannot generalize the results. We have to go up beyond the discharge, and we lack blinding. We can conclude, though, this improved the musculoskeletal. This program improved the function, decreased the pain, improved overall sports performance in runners with femoroacetabular impingement. And thank you so much.
Thank you, Dr. Muhammad. The second speaker will be Dr. Ahmed Hussein Omar, lecturer of Qasr Al Aini in Cairo University. And his title will be The Evolution of Nerve Transfer in Neurotrauma.
Good morning, everybody. First of all, I want to introduce myself. I am Dr. Ahmed Hussein. I am a lecturer and a consultant of neurosurgery Qasr Al Aini. I have my fellowship training in UW Medicine, UAE, focused on nerve. نقرب شوية. هو مش شغال؟ سوري للليزر. عايز في مشكلة يا جماعة في البوينتر أو حاجة؟ ممكن يمين مش مع دوكس يمين مش مش عايز. Okay. So this is my disclosures. So the background of nerve transfer, many years before, we used the nerve transfer as a reasonable solution for treatment nerve injuries. In this lecture, we are not talking only about the role of nerve transfers in brachial plexus and nerve surgery, and also we will talk about the role of nerve transfers in a very trendy hot topic nowadays, which is the spinal cord injuries and its role in nerve transfer. So let's review some basic anatomy and physiology about the nerve injury and repair. When we have a nerve injury, there is a starting to do with an inflammatory process at the site of injury, macrophages, Schwann cells, and then start to come to the site of the injury and then start the regeneration process after the degeneration. So the basics of nerve regeneration, that the nerve grow with the rate 1 to millimeter per day. And this is very important for us because we decide when to do surgery according to the rate of growth and the distance of the site of injury from the nearby needed muscle to be reinnervated. The second item, that the muscle undergo irreversible change within 12 to 18 months. So we are in a hurry and we have a very big problem and dilemma to reinnervate the muscle before it degenerates. So we have a very important mnemonic in nerve surgery that distance equal time, and time equal the muscle, and the muscle equal the function. So if you do a nerve transfer or any surgery late, you will get no function because the muscle will be degenerated. So distance equal time, and time equal muscle, and the muscle equal function. So this is very important concept in nerve surgery, that you need to reinnervate before the muscle regenerate. So our concept in nerve repair, that this is the main concept of nerve repair, that if you have two ends of the nerve in the field, so you will trim the nerve endings and then trim the nerve endings and do what's called end-to-end repair, which give you the best results to restore the continuity of the nerve. If you have a very big gap, so you can, if the little gap, you can mobilize and also do a direct repair. But if you have a big gap, you can do a nerve conduit or nerve cable grafting to jump from here to here because the gap is very big. But unfortunately, this is not the typical situation in nerve injuries, because in nerve injuries we always have some challenge. They may be very extensive damage to the bed, very proximal stun. You can't get the proximal part of the nerve and the distal part of the nerve, and you can, maybe the patient is presenting very delayed, and this is very important, and that's why we are talking today, because some patients are presenting very late, so they lose their hope in primary repair, or sometimes you have a very big wide gap, so you can do the neurotization early. So in this issue, you have two solutions. You can do a tendon transfer or a nerve transfer. Tendon transfer will distort the biomechanics of tendon and muscle biomechanics, and you can do another option, which is the nerve transfer. So what is the nerve transfers? Nerve transfers is a healthy one, expendable, functioning nerve, which is a donor nerve, and rerouted to connect it to a non-functioning damaged nerve to restore the function easily. So this is a map of Egypt. If we are here in Luxor and you need to transfer something to Giza or Cairo, it will take a very long distance and too much time. It's much more easier to transfer it from Alexandria instead of Luxor, because Alexandria is very close to Giza. This will save time and this will save also distance. This is the main concept of nerve transfer. So the nerve transfer easily, if the green one is a normal nerve and the muscle is paralyzed with the red nerve which is paralyzed, you can do a proximal repair. You can do a proximal repair high, and it will take time to reach the muscle. But if you cut the healthy nerve and re-implant it here to the nerve here, will save the time and save the muscle. So this is what's called a functional repair rather than an anatomical repair. So we are not restoring the continuity of the nerve like the radial nerve. No, we will do something like, we will take a branch to the distal branch of the radial to re-innervate the muscle. So this is what's called a functional repair rather than an anatomical repair. So the concept of nerve transfer, that we need to do a tension-free suture. This is very important. We need also to do one suture line instead of two suture lines. If you are doing a cable grafting, you will have two suture lines. So the nerve signals or axons will pass through two suture lines, and this decreases the results of regeneration. But if you do a nerve transfer like in this, you have only one repair site. So the axons will need to cross through one repair site, and this improves the results of nerve transfer and nerve repair. So, and also you can do the surgery in a very good, well vascularized area, away from the site of injury, away from the trauma of the bone and vessels, and you are very close to the target organ, which is very important to us. You need to re-innervate, for example, the biceps, so you are very close to the biceps instead of repairing the biceps high in the brachial plexus. And also it facilitates the rehabilitation, especially when you are using the synergetic muscles. So this is the main concept of nerve transfer, which is called donor distal recipient proximal. We need to cut the donor nerve as much as distal and re-implant to the recipient as much as proximal, like in this photo or in this one. To do what? To have attention-free sutures and extreme range of motion. You need to make sure that after you do the repair, even in the extreme range of motion, there is no tension on your sutures to give the best results. Advantage of nerve transfer is a target end organ distance. It crosses what's called the mismatch, the sensory motor topographic mismatch. If you are repairing the radial nerve with a sural graft, the sural graft is a sensory one, the radial nerve is a motor one. So this is called a topographic mismatch, and the difference in diameter it's a diameter or size mismatch, and this also lead to decrease the efficacy of the transfer. So that's why the nerve transfers is widely used nowadays to overcome the problems of direct nerve transfer. So I know that all of us are asking, if I am taking a functioning nerve, lead to paralysis of the muscle, the healthy muscle, to restore a function of another muscle. Yeah, this is a very big dilemma. But when we are choosing our motor transfer, or even there are sensory transfer, we need to use an expandable donor motor nerve. Expandable motor nerve that sometimes you have more than one muscle doing the same function. So you will take one nerve to one muscle to take it to re-innervate. For example, you can take the nerve to pronator teres because the pronation of the arm may be continued by the pronator quadratus and go on. Other muscles can do the same functions. It will not that big problem or that big issue. With physiotherapy, you will restore the same function, almost grade 5 motor function. And it should be very nerve. This is the main target for us, and it should be also a size match. You can't transfer a sensory nerve to a motor nerve. You need to transfer a motor nerve to a motor nerve with the same size match. This will ensure the biggest large number of axons to be delivered to the injured muscle. This is an example here. If we see, this is a posterior approach. Here you can find this one is the triceps towards the nerve of the radial nerve between the two heads of the triceps. It can be transferred to the axillary nerve to restore shoulder function in upper thigh brachial plexus. Even here, if you have an injury in upper thigh brachial plexus in C5, C6 upper trunk plexus, you have a paralysis in the biceps. You have a problem in the musculocutaneous. So you can take a transfer from the median nerve or the ulnar nerve to transfer it a fascicle to the musculocutaneous, or more specifically the biceps branch of the musculocutaneous to restore the biceps function. Even in radial nerve palsy, you have different approaches. You have different techniques. You can take you can re-innervate the recipient. You can re-innervate the PIN and the ECRB to restore the function of the wrist extension and the finger extension, and instead of going through the damaged area of humeral fracture. So, and this is the diagram showing the radial nerve. This is the radial nerve on the left side, and this is the okay. So what about the difference? What's the difference with in spinal cord injury? Spinal cord injury has different concept. The injured area, you lost the upper motor and lower motor injury, and the upper part above the injury you have intact upper and motor neuron, and below the injury you have intact lower neuron and you lost the upper motor neuron. This is very important concept. You can do your nerve transfer even late in patients with spinal cord injury. They lost only the upper motor neuron control, but they still have the lower motor control, so the muscle is still working or still have motor unit potential. So the tetraplegic or quadriplegic patient have different problem because they have problem in feeding and hygiene and care, and the upper limb restoration function is very important to them. So the target of re-innervation is you can restore the elbow extension, the key gripping, and the finger grasping, which is very important for you. So different trials and literature talking about this issue. This one was published in the Lancet, saying that the nerve transfer is safe and effective and can restore function very good in tetraplegic. And even nerve transfers in the upper extremities gave good results also in this one. So 50% of the patient can get benefit, but only 14% doing surgery. There must be a gap. Different papers and literature said about the gap because physician perception of upper extremity reconstruction in person with tetraplegia, there is a very big gap and lack coordinated cross-specialty between the surgeon and the physiotherapist. Another paper published in Disability and Rehab in 2021 talking about that there is a lack of information between the physiotherapist and the caregivers and the patient about the options of hand reconstruction and nerve transfer. Another one was also published in the Korean Academy showing this a problem. So where do we stand? We are standing here today with each other, bridging the gap between the surgeons and bridging the gap between physiotherapists for the hope and the healthy and the best of our. And I have only 30 seconds and I'll finish. So who are candidates for nerve transfer in tetraplegia? Patients with 6. When surgery should be done, according if you are talking about a lower motor neuron or upper motor neuron. So what kind of nerve transfers? Different nerve transfers can be done to restore the needed function, and nerve transfer versus tendon transfer is a very big dilemma, and a lot of publication discuss this one. But at the end, medicine add days to life, physical therapy add lives today. So we should work as a team for the best of our patients, and thank you.
شكرا دكتور أحمد حسين.
شكرا يا دكتور.
Now we would like to welcome Dr. Gizin Ergizin, Assistant Professor of Istanbul University. Her talk is under the title of Temporomandibular Joint, the New Guidelines and the Evidence-Based Threats. You can start, Doctor.
Hello and welcome everybody. The temporomandibular joint is my area actually. I'm working with TMGs and also with orthopedic cases. So I'm trying to give you a summary of the literature in the last year, okay? So we are coming from Istanbul, Turkey at the beginning. So it is known as capital, but it is not capital. It is so crowded, it is known so much. And this is our university that we are coming. It is Istanbul Medipol University. It is the one of the campuses. So you are always welcome if you want to visit. So let's start with what is the temporomandibular disorders. It is called as well temporomandibular dysfunction, but nowadays we are using as a disorder term. So it is an umbrella term for craniofacial pain syndrome, and that include alterations in masticatory muscles, temporomandibular joint, and other related structures. So we have to take the person as a whole while we are treating, because it is really related with the other muscles and the chain of the muscles. So we have some signs and symptoms, which is headache, eye problems, some mouth, teeth, ear problems, jaw problems, neck problems, and the throat. That's why here we have a neck problems. It is affecting whole body. And for the diagnosis, actually the gold standard is MRI, but in clinic, if you would like to determine which kind of temporomandibular disorders, it is used research diagnostic criteria for temporomandibular disorders or diagnostic criteria for TMD. So we are classified the TMDs into 3 groups, which is muscular, disc, and the arthralgia. So the treatment for temporomandibular disorders, when we search at the physiotherapy, we are seeing 202 results between really much years as a clinical trial and randomized control trial. So it is really less. This rehabilitation area has the gap actually. And when I'm searched with as a physical therapy, the result is going to 245 results. It is still so less. So when we look at the years, we are seeing that 2020 and 21 having the higher researches, so we can say it is getting popular within physiotherapists and also dentists. Same here. In the last year, we have only 13 results, which we had a research about the reviews. So let's see what kind of systematic reviews we have and get a summary of the rehabilitation effectiveness. So when we look at this review, we are seeing the manual therapy application to the craniomandibular structures is significantly improved the pain and the maximum mouth opening, and it is affecting the pain by the way of the perception of the pain. So the patient is educated by this manual therapy. And as types of manual therapy, we have 5 different in the review, and when we are comparing with the sham group, control group, or self-care, exercises, splint, kinesiotherapy, photobiomodulation therapy, we are seeing that the CMMT have a better effect or the same similar effects in the temporomandibular disorders as a pain and the maximum mouth opening. So in the manual techniques, we have a low to moderate quality, so we need more studies, as you can see. We can say that the cervicocranial region can be used myogenous temporomandibular disorders to get improvement in maximum mouth opening and reducing the pain. And still we don't know the best manual technique in arteriogenous TMD. So here we are seeing another space in the literature about physiotherapy, or let's say manual therapy. And the low level therapy with a different wavelengths and the comparison of the transcutaneous electric nerve stimulation effects we are seeing here. So we have the literature finds that low-level laser therapy having a better effect of the TENS while we are comparing with the placebo group. So for while we get a better effect, we can use the wavelength of 910 between 1,000 and 100 kilojoule, nanometer. So here there is a result of the literature. So here we are seeing in the L3, which is the third week. So one treatment we are seeing the best evidence is here with a low-level laser therapy while we are comparing with the others. And also here we have the exercise therapy for the disorders. And while we evaluate the pain and the passive maximum mouth opening, we are seeing that exercise therapy decrease the pain, increase the pain pressure threshold, and active and passive maximum mouth opening decrease. So on pain, if you would like to get a more effect with the exercise therapy, you should combine with a splint to get a better results. And on pain pressure threshold, exercise therapy has better effects on the manual therapy, or while we are having the comparison with manual therapy and electrotherapy for active and passive maximum mouth opening as well. So while we are saying exercise therapy, what is it included in the literature? Mobilizations, translations, tractions, stabilization, splints, therapeutic exercises like isometric or isotonic or the resistive exercises. And we have relaxation exercises for masticatory muscles. So all muscles included here. And these exercises should be applied at least 10 minutes, 3 times per week for a long of 4 weeks. And for biting endurance exercises to be effective, we have to apply 16 sessions twice a week for 8 weeks long. And for mobilization and the jaw self-care exercises, and here we are seeing something different, which is diaphragmatic breathing exercises should be added to therapy, and we have to use it the 2 sessions per week for 5 weeks long. So the patient doesn't have time in a week enough. So biting endurance exercises and mobilizations with the jaw self-care more applicable. And also we have Roccabado's 6-to-6 exercises, which is known very well. So while we are comparing only occlusal splint or the combined with occlusal splint, we are seeing in exercise alone or combined with occlusal splint, increasement in the masticatory strength and the resistance, so that's stability. In occlusal splint, also we are having the result to have the functional posture of TMG, which is we are called the free position, we can have with the occlusal splint. So while you are combined both of them, you have the proper posture, and then you are adding exercises to have a better effect on the joint. So if we have a patient who has the disc displacement without reduction, we can use manual therapy and exercise to get effective results in pain and maximum mouth opening. And in the last years, we are talking so much about the stress with the TMG. So in a review of psychological therapies for temporomandibular disorders, the cognitive behavior therapy has been found the most effective therapy in a psychological way. And here, okay. So 10 transcutaneous electrical nerve stimulation is also relieve the pain and increase the maximum mouth opening. But while we are comparing with ultrasound and lasers, it has the same effectiveness. So you can use all of them to relieve the pain. But we don't have a results of different type of TMD. So in the low-level laser therapy, again, it is also reducing the pain intensity and mandibular functions if you are using the wavelength of 800 to 1050 nanometer as a dosage of 25 joule ratio centimeter square. So laser has more effect on the placebo, but same with the ultrasound and the transcutaneous electric stimulation. So thank you, şükran and teşekkürler.
Thank you, Doctor, for your presentation.
شكرا بروف دكتور هالة قاسم Dean of Faculty of Physical Therapy Delta University. شكرا بروف دكتور عبير الشيوي Professor of Physical Therapy for Neurology and Neurosurgery Faculty of Physical Therapy Carver University. شكرا. هنرفع الجلسات للصلاة وللبريك لمدة ساعة. شكرا.